Hey everyone, welcome back to GME Compass. I'm Julie Gualano, co-founder of GME Compass. Today, we're going to dive into one of the most commonly misunderstood operational areas in graduate medical education, PEC versus CCC, or in other words, what data and information should be reviewed where. This is one of the biggest areas of confusion that we see across residency and fellowship programs. It can create major operational inefficiencies, documentation issues, and even ACGME citation risks where the lines begin to become blurred. So today, we're going to simplify exactly this: the purposes of both the Clinical Competency Committee and the Program Evaluation Committee, what data belongs in each meeting, common mistakes that programs make, and how to create a cleaner, more defensible workflow moving forward. If you've ever sat in a committee meeting wondering, why are we discussing this here? This video is for you. Before we get started, just a few disclosures. We have no financial disclosures related to this presentation. Everything that we're discussing today comes from our broad experience in graduate medical education leadership and operations. This presentation reflects our personal knowledge and experiences, not any current or past institutional role that we may hold. At GME Compass, our mission is to help to guide GME professionals through complexity with more clarity, structure, confidence, and control. By the end of today's video, you should be able to differentiate the purposes of the Program Evaluation Committee as well as the Clinical Competency Committee. Identify what data belongs in each committee, recognize the common ACGME citation risks, and utilize a repeatable framework that helps to organize the committees more effectively and efficiently. And honestly, if you remember one thing from today, remember this: PEC evaluates the program, CCC evaluates the resident or the fellow. That, at the end of the day, is your biggest take home piece of information. So if you are a new program coordinator or a new program manager and you just feel like you're drinking from a fire hose that is information overload, if you take that one nugget of information back with you, that alone will help you to adjust your framework of how you're looking at data, how you're looking at meetings, how you're writing your minutes, and that alone will change your operations and make you a better program coordinator, a better program manager. So, why does this matter? I wanted to intentionally pause on this quote because I think that it captures the issue perfectly. If everything is reviewed everywhere, nothing is reviewed well. And this is exactly what happens when PEC and CCC lose their true identity and intention. Programs begin to mix agendas, they combine discussions, they review the same data in multiple places, and then that starts to create confusion about accountability. So the goal is not for both committees to review everything. The goal is for each committee to review the right things. And why does this matter operationally? Because blurred committee roles create confusion, inefficiency, poor documentation, incomplete reviews, weak action planning, and increased citation risks. In fact, this is probably one of the most common operational gaps that we see across programs. Sometimes the meetings are happening, but the structure that's happening behind them and the infrastructure that builds those committees is weak. And ACGME reviewers can identify that extremely quickly. So here's the simplest framework that I can give you. PEC asks the question, how is the program doing? CCC asks the question, how is the trainee doing? PEC is system focused. CCC is individual focused. That means that your program evaluation committee is going to evaluate your curriculum, trends, outcomes, recruitment, your survey data, and your program improvement opportunities. CCC is going to evaluate your milestones, professionalism, your resident progression, readiness for advancement, and graduation readiness. This distinction is absolutely everything. The high level difference: Program Evaluation Committee, I'm going to say this over and over and over again because it's so important. PEC is program focused, systems oriented, and improvement driven. So, process improvement driven. That is really what motivates this meeting. CCC is resident focus, fellow focus, trainee focus, progression oriented. So, you want to make sure that your trainee is progressing through a good trajectory of their training program, and it's competency driven. So you're focusing on the different competencies that your trainee needs to accomplish or achieve throughout their training program. So your PEC is going to produce your program action plans, your annual program evaluation, your system-wide improvement initiatives. Your CCC is going to produce your milestone ratings, and that's going to be ultimately uploaded into the ACGME. Your trainee advancement decisions, as well as any remediation recommendations. And these are very different committee functions. So let's deep dive into the Program Evaluation Committee specifically. PEC stands for Program Evaluation Committee. This committee is required by the ACGME and it oversees the annual program evaluation, continuous program improvement, as well as your action planning. This is important because the PEC should not function as a once a year compliance checkbox. And that's a big mistake that many programs and institutions make. So it should function as a constant, ongoing quality improvement engine for your residency or your fellowship program. And you want to keep oiling that engine to keep it going. So, what does it focus on? It focuses on program outcomes, different survey trends, your curriculum effectiveness, the competencies, and the information that's coming out of those curricular experiences, as well as action planning. So notice how all of these things are system level concepts. PEC is asking, how is the educational environment functioning overall? Is the educational learning environment, is the clinical learning environment a well-run operating machine? Its core responsibilities is to review your outcomes, faculty development, curriculum, ACGME survey data. So then from there, the committee is going to identify any strengths, weaknesses, opportunities, or areas needing improvement. That can also be known as your SWOT: strengths, weaknesses, opportunities, and threats. So that means that you're looking at internal and external strengths and weaknesses of the program and the training environment. So PEC should constantly be asking, what can we do to improve operationally or educationally within our program and our training environment? This is where many programs begin to mix the responsibilities. Data that belongs within PEC includes things such as board pass rates, recruitment outcomes, aggregate trends within your program, overall case log trends, and attrition patterns. What does not belong in the Program Evaluation Committee? Any individual resident performance metric. That belongs in the CCC. PEC should focus on patterns and trends, not any isolated resident concern. So, what should PEC be analyzing deeply? Things like trends over a period of time, benchmark comparison, survey themes, gaps in your curriculum, faculty engagement. That can be a lot of things. That can be faculty engagement in faculty development. It can be engagement in the surgical environment in the OR. It can mean evaluation compliance. That is something that a lot of programs struggle with. I know mine did. I want to emphasize something really important here: survey themes, not one isolated negative comment. PEC should identify meaningful patterns that require systems level analysis or intervention. This is something that I tried to drive home in my program so hard. And we just couldn't get it to a point where leadership really understood what that meant from an organizational strategy level. But this is really incredibly important. The PEC isn't just looking at your ACGME survey and saying, oh, that looks really great. We did fine here. Or we were a standard deviation off of here. We really need to talk about it. It's about taking a bird's eye look and trending these things over time and identifying different gaps, different opportunities, so that you can then use that information as a recommendation and then ultimately as a program evaluation or a process improvement plan, and then address and identify and correct from there. PEC should identify meaningful patterns that require systems level analysis or intervention. Now, we talked a little bit and we alluded to things that are not the CCC. So let's actually shift to what is the CCC. It stands for the Clinical Competency Committee. And this committee is also, much like PEC, required by the ACGME. However, unlike PEC, your CCCs focus specifically on individual resident and fellow performance. This committee is deeply grounded in resident and fellow individual assessment. The CCC assesses your milestone progression. Are your residents or your fellows going on a nice line within their milestone progression? Or are you seeing a lot of this? Or are there really big dips? And those dips might not mean a gap in knowledge, skill, or ability within the resident or the fellow. It could be lack of evaluation opportunities. And we're going to talk about that later because that's where something is affecting the CCC, but actually needs to be recommended to go over to the PEC. So you want to assess and take a look at your milestone progression, EPAs, if it's applicable in your program in your department, professionalism, readiness for advancement. Based upon that assessment, the CCC may recommend promotion, remediation, additional support, as well as readiness and preparedness for graduation. This is a highly individualized review process. It's a deep dive into each individual trainee's learning experience and progression. So the CCC is going to focus on the resident or the fellow progression, your achievements within your milestones, professionalism, and readiness for graduation. This committee should be asking, is the resident developing appropriately toward independent practice? And I know that might seem like a silly question to ask for maybe a first year or a second year resident because you might have 2 or 3 years left to go, right? But you still want to be asking that question because the question isn't, is this resident or fellow prepared for independent practice? It's, are they developing appropriately? Are they going on a nice upward trend? Data that belongs within this meeting are your evaluations, and those can be all encompassing of your 360 evaluations, such as your self-evaluations, faculty, maybe nurse evaluations happen throughout the year. They might not happen at every CCC, but you want to make sure that those are part of the all-encompassing evaluations at some point in the academic year. Procedure logs, in-training exam scores. We mentioned milestones and professionalism concerns. What does not belong in the CCC? Program-wide trends. That belongs in PEC. Again, CCC evaluates people, PEC evaluates systems. So like I had mentioned before, you might see a dip in your third year class in one of their surgical skills milestones. And when you actually look at it to see why there's that dip, and you realize, oh, that's because only one person evaluated them, even though I sent out however many evaluations or my tip reports or whatever that might be. That's something that then gets kicked over to PEC because that is a systems-wide issue. That's a process issue. And then what do you analyze within the Clinical Competency Committee? I talked a lot about the resident trajectory. That is extremely important. Improvement versus decline, making sure that even if it's small, even if it's minimal, that you're going upward. Consistency across evaluators. You want to make sure that you have a nice number so that you are making a well-rounded decision that isn't happening in a silo. professionalism concerns, communication issues, as well as clinical reasoning. So the CCC is ultimately trying to determine, is this resident or fellow progressing appropriately? If they are not, what intervention might be needed to help them to be successful. And then this slide is a comparison slide, and it really summarizes the relationship between the two meetings. So your PEC is program, aggregate data, action plans, and your APE. CCC is resident, individual data, milestones, and advancement. And yes, they may meet at very similar intervals, but they have fundamentally different purposes. When back in the day, when CCC and PEC were new, our program actually used to do our CCC, and then immediately following we did a PEC, because majority of the members were overlapping, not all of them, but majority of them were overlapping. And while we were blocking clinical schedules and such, it just seemed to be logistically easier. However, what we found was, one, the PEC wasn't getting enough attention that it really needed, because the CCC requires a lot of data, a lot of information, and a really good in-depth review into everyone. And then with the PEC, the way that we had it was the second meeting, we would rush through it. But it also really made it hard to take off a CCC hat and put on a PEC hat. We found that we were kind of blurring those lines, and we were having conversations in the opposite meetings because the times were so close that the lens that we were looking at the data, the things or the problems or the issues were so close that they were becoming too blurred and too gray. We personally in our program found that it was easier for us to stay focused on the vision and the mission and the purpose of the meeting by having them on separate times and separate days. So this slide highlights one of the most common mistakes. Wrong is discussing individual resident concerns extensively within the program evaluation committee. Right. CCC handles the resident performance, and the PEC handles the system analysis and the program improvement, going back to my evaluation example. So this separation is really critical. And I had said in the last slide how we had struggled with really finding a process that made that identity clear so that we could be the most efficient as we possibly could. That separation was really critical for clarity, compliance, workflow efficiency, as well as documentation defensibility. I often, would always say, I try to look at every situation of, what if I wound up in a resident appeals committee meeting? What if I wound up having to defend a process or something in court? You don't know. You always think that may never, ever happen to me. But the reality is it could. And that doesn't mean that you have to always be defensive and you have to think, oh no, that they're going to come at me. But you do want to look at, am I documenting everything clearly? If I'm here one day and not the next, can someone pick this up and understand what I'm trying to say? If a third party, if there's an outside pair of eyes that are looking into my documentation, my program in both of those meetings, can they really understand the progression, the data analysis, the conversations, and the important points that were based off of information and documentation versus emotion? Will they be able to read and understand them? Can you defend those decisions and those processes that came out of the meeting? Other common mistakes might include reviewing program trends inside of CCC, poor documentation separation, missing action plans, CCC decisions that aren't tied to evidence. I just spoke to that just a moment ago, or unclear committee identities. These issues may seem small operationally, but they can create major downstream compliance problems. Again, always wearing the hat of, if I have to defend this to my DIO, to my chair, or a resident appeals committee, can I defend how this decision came to be? These are real citation themes. Things like ineffective PEC oversight, poor CCC documentation, milestones that are not tied to tangible evidence. Often the issue is not necessarily lack of effort. It's generally usually tied to lack of structure. It can be an inefficient workflow, maybe not having a standard form or a document or a process or something that leads to the lack of structure that causes that breakdown. Maybe not having continuity that's equal across all trainees for CCC. Or PEC was you're trying to trend data if you're constantly changing and you're constantly kind of like a tennis ball all over moving and shifting your focus, you can't really focus and trend on anything. You don't have any skeletal infrastructure for your meeting. So this is important. The PEC and the CCC should communicate. And this is where it kind of gets confusing. It can get confusing for even the most tenured program coordinator and manager, but especially if you're a newer program coordinator and manager and trying to wrap your head around all of this. They should communicate. What they shouldn't do is become the same committee. So, for example, if a CCC notices that multiple residents are struggling procedurally, that could suggest a curriculum issue. So, the CCC is going to identify this trend, but then they're going to recommend it to the PEC, and the Program Evaluation Committee will then evaluate the system. And then an action plan will be created. That is an appropriate workflow relationship. It's kind of interesting because these two meetings work in a silo, but don't work in a silo at the same time. They really are intended to complement one another while having very defined individual purposes. Again, documentation matters tremendously for so many different reasons. PEC documentation should include your minutes, your annual program evaluations, as well as your action plans. Your CCC documentation needs to include your milestone ratings, resident summaries, as well as any notes with regard to your advancement. Most importantly, keep those workflows separate. So now let's come back to the core framework again. Ask yourself one question. Is this about a system or a person? If it's about a system, it belongs in PEC. If it's about a person, it belongs to CCC. This simple framework can eliminate an enormous amount of confusion. So let's walk through a quick example. 3 residents are struggling with presentation communication skills. Wrong approach. Discussing all 3 residents in the PEC. The right approach would be that the CCC is going to address each resident individually, how each resident is struggling with those communication skills, and how their milestones should be assessed accordingly, as well as how we can set them up for success. What tools or what resources might they need to positively progress in that area? But then at the same time, the PEC is going to evaluate, do we have a broader communication curriculum issue? Is there something that needs to be implemented? Is there something that needs to be changed or tailored within the program? Because are we starting to see a trend? And that's the distinction that's really critical. Tools that you should be using. Operationally, there are tools that make things so much easier. So things like separate dashboards, milestones tracking systems, survey trend analysis sheets, action plan trackers, separate meeting templates. Templates create consistency. Consistency creates defensibility. I feel like that's something that I say all the time. I need to put it on a t-shirt. You can find, I use New Innovations, so we would use the portfolio module in there. And for our Clinical Competency Committee, for Program Evaluation Committee, we would just use standard documentation and create packets. But for CCC, we would use the portfolio module, but we also had dashboards that were standardized, that were tracked. Our faculty had standardized review systems. Our review teams all had the same standard information. And then our CCC lead would use the same standardized form where we would assess, approve milestones, resident progression in different areas in the training environment, and what status they were going to be advancement. And all of our detailed notes would go in there as well as in the minutes. And then similar but different for the PEC, we would have a very detailed minutes template. But then we also had different trackers, different dashboards, different red, yellow, and green systems that we could look at and we could use for our different metrics that we're analyzing. Some of those things you can actually find on our Etsy shop. If you would like access to those digital downloads, they might be helpful to you. And I can actually, there's many that aren't in there yet, that there's even more that I had created that I can work on getting up and getting uploaded for everyone if that's something that there's interest in. But again, templates create consistency and consistency creates defensibility. If you remember nothing else, remember that. That's extremely important, not only for PEC and CCC, but really all things in terms of program accreditation and oversight. So again, documentation's everything. Your documentation should clearly demonstrate what was reviewed, what decisions were being made, who is responsible, and what follow-up is occurring. Weak documentation is one of the biggest vulnerabilities that programs face. A few last final operational tips. Don't ever mix your agendas. Keep separate folders, separate files. Always prepare your data before the meeting, not the night before, not the morning of, well before the meeting so you can analyze it and be adequately prepared. Standardize templates wherever, whenever possible. The more structured that your process becomes, the easier these committees become to manage. As always, thank you so much for joining us in this conversation. We hope that this helped to clarify the evolving operational relationship between the Program Evaluation Committee as well as the Clinical Competency Committee. If this topic resonated with you, we would love to hear from you in the comments below. What are some of the workflows and tips and tricks that you have found to help you to organize, track, and document your CCC and your PEC? If you found any value in this video, please like, subscribe to GME Compass, follow us on our socials, and check out our digital downloads and resources and toolkits that are designed specifically for GME professionals. Thank you again for being here, and we'll see you in the next video.